Welcome everybody to this PHRN Wednesday webinar. This is actually the last webinar for 2019, but we're looking forward to bringing you some more webinars next year. Today I'm delighted to welcome Associate Professor Rachel Moran from Curtin University, who's going to talk about the use of linked administrative data to evaluate continuity of primary care. Now, throughout the presentation, you won't be able to ask any questions, but if you have questions, you can type them into the question box, which you can see, and at the end of the presentation, we'll read out the questions and ask Rachel any questions you have. So I think we'll get started. I'll just hand over to Rachel. I can do this right. There we go. Present. There we go. Now hopefully you can now see Rachel. Voila.
Okay, well, thank you very much for that introduction, Felicity. So I've been working with linked cross-jurisdictional data now since about 2008, and that was due to this time-limited memorandum of understanding we had between the Commonwealth Government and Western Australia. So I've been very privileged to have quite a long period of exposure to Commonwealth data, so it's NBS and PBS data, which on several projects, both led by myself and by Professor Darcy Holman. Initially, my work was really on the consequences of an ageing population and the use of Australian and Commonwealth and the healthcare system. But more recently, I've been focusing on patterns of primary care, and today I'm going to present an overview of the work done on primary care. I'm just going to move myself, there you go. Primary care that we've been doing over the past sort of 4 years. So I'm going to start off with a bit of background to what initiated this particular project, and then I'm going to showcase 3 studies just in the matter of time. And for those of you who are attending the Health Services Research Conference in Auckland in December, we are actually giving a symposium on this work on the Thursday. So just a bit of a plug there. Okay. So why did we come to think about doing this study? Well, as you know, Australia, like all industrialized countries, has got an aging population with a very high prevalence of chronic illness and an ever-increasing expectations of service delivery. And policies to reduce this sustainable demand on services have been really about shifting service delivery from the acute care to the primary healthcare sector. And this is to help reduce costs and demand on hospitals. And the mechanism that's thought to that this sort of shifting is supposed to act by is this idea of chronic disease management. So this is about preventing chronic conditions reaching a level that require acute care or intervention. And all this really relies on this underlying theory of what's called the ambulatory care sensitive conditions. So this is a theory that proposes that admission to hospital is considered to be potentially preventable if you have early diagnosis and or earlier intervention by primary care, which in Australia is really primarily general practitioners. So this is the phenomenon, if you think about it, that we were hoping to capture in our data. So it's about longitudinal primary continuity of care, and it's about differentiating this idea of reactionary care from what we classify as proactive ongoing contact. So reactionary care would be the situation where somebody's in the community with a chronic condition, and they have an exacerbation of symptoms, and they therefore prompts them to go to their GP. They receive care for those exacerbations of symptoms from their GP, and then they go back out to the community. Everything's going fine until they get another exacerbation. So you can imagine that really going to the GP is prompted or is reactionary to some change in their health status. And what we're hoping to shift from by this idea of chronic disease management is rather a proactive ongoing contact with the primary care physician, so that regardless of how they're tracking in their health status, there's sort of things can be done and it can be kept an eye on. And the idea is that as things start to change, that the changes in management of their patient's condition can happen prior to the exacerbation of their symptoms. So this is the chronic care model, which is about from reactive to proactive behaviour, and it really relies on resources and policies, an organised healthcare system, and particularly an informed and activated patient and a prepared and proactive practice team. And all this is hopefully going to lend itself to improved outcomes for patients. So in Australia, our policy response really has been about focusing on improving regularity and the quality of healthcare provided by GPs to older Australians and those with chronic diseases. And this really started in 1999 with Medicare introducing some new items which were designed to improve care received by seniors, especially in managing their chronic diseases. So this was the enhanced primary care items, which were initially annual health assessments of patients aged 75 plus and 55 plus if you were Indigenous, multidisciplinary care plans and case conferencing. Now in 2004, the EPC items were redesigned in response to a lot of negative feedback by GPs. And this was really that they were complaining that there was too much administrative burden, which allowed them to use them. So the EPC items were rebranded as chronic disease management items. And since then, they've sort of slowly changed over time to expand the patients that it involved. And we, I'm speaking in the royal we terms now here, really have evaluated changes in regularity associated with the EPC CDM exposure using linked administrative data in WAC years age 65 plus. And this was, as I say, due to this time limited MOU from the Commonwealth Government. So what we've been using is this metric which we've coined as regularity, and this is really about measuring using MBS data, exposure to the GPR, visits to the GP at regular intervals. So the metric is built from individual level linked data, and it really measures how well services are distributed and not how often. So there's a little schema on the screen here. So if you imagine an ascertainment period, which we usually use 12 months, but it could be 2 years, could be 3 years. We can capture from our MBS data every time somebody has a primary care attendance, and we can capture the number of days between these services, and then we can calculate what we call a regularity score, which is just really 1 over 1 plus the variance of the distribution of those services in days. So regularity is a construct that's different to frequency of contact. We've got 2 example patients here. Jim, both of them in fact have a frequency of 4. They have, in the particular ascertainment time, have 4 GP visits, but you can see that Jim has much more regular contact than Joe. So our previous research has shown that regular GP contact is associated with increased time to death or hospitalisation in some cohorts, and it can be modified without impacting frequency. And these are the results from a study that was done by a previous PhD candidate of myself, which he looked at patients that were exposed to the EPC compared to those who were unexposed between 2001 and 2006, and looked at the outcome being their regularity or their outcome being their frequency, obviously adjusted for confounders, etc. And you can see that those exposed compared to the unexposed compatriots had a much higher regularity, but their frequency of contact didn't change. And this is very important because we don't want to just put additional burden onto the primary care system, or to have people just going to the doctor more frequently than they actually need, because that just increases costs. Now, we know also from data that regularity has generally increased for people with, this is in the diabetes cohort, in WA between 1991 and 2004. There's now a small but significantly reduced probability of people in the low regularity, and an increased probability of people in the high regularity classification over time. And we also know from previous data that regularity tends to reduce diabetes-related potentially preventative hospitalizations, both in rate, which is the far left side of your screen, cost, which is the middle graph, and also in bed days. And this is really some modeling that's looked at both the rate of incident hospitalization, as I said, cost and bed days in 2 eras, era 1 being the orange line and era 2 being the gray line. So it's reduced in both eras, but it's starting to actually wane. The actual impact of regularity seems to be lessening over time. So now I'm going to talk about 3 studies we've done with a recent NHMRC project, which has been running for the last 4 years. And this has been using some of the old WA data, some 45 and up data, but also we've got a new part of this study has actually been to do an additional linkage into Commonwealth WA state data using privacy preserving linkage with the Curtin Data Linkage Unit. So the first study I'm just going to very briefly overview is done by a PhD candidate, David Ewens, and he looked at basically making a new mode of regularity, or looking at regularity and how it is, what methods of measurement we can use in administrative data. So the problem was that with our current metric, regularity, it's highly associated with frequency. And this obviously can be accounted for. This is what we do in models. We adjust for frequency in the models. But ideally, any metric should be really independent. So in this study, David took a study population of West Australian adults aged 18 plus. And this is from our old data from 1990 to 2004. So it's not contemporary data, but it shows the effect. And this is about developing this new metric. And the data collections we used were the MBS items, the hospital morbidity data system, mortality records, and also the WA electoral roll. And the special thing about these data is that we've got historical electoral roll, which enables us to catch people when they leave the state. So the analysis cohort for this study was people at risk of diabetes-related hospitalisation, and also those with those with 2 or more GP visits in a year. And this is actually the minimum required for the calculation of the regularity index. So the aims of the study were to assess whether the existing and our new regularity index, which David actually generated for this study, are associated with frequency of contacts, and then secondly to assess whether any of these associations with the frequency bias the estimation of hospitalisation outcomes. So the indices that David tested here were one that we noted in the literature, which is a very simplistic index, which really breaks up the ascertainment period into periods. So this is a person will be given a score from 1 to 4, depending on the smallest measure of time that they had their GP contact. So if they only had one GP contact a year, they would be classified as an annual contact, number 1. If they had sort of monthly contact, they would be given a score of 4. The second indices that we tested was our existing regularity index, which I've already discussed, and the third one is a new regularity index, which David developed specially for this work. And whereas the existing regularity index used 1 over the 1 plus the variance of the days, the new regularity index used a coefficient of variance, and this actually means it has less reliance, or theoretically, until we test it, less reliance or less with correlation, if you like, with frequency. So some very high-level results of David's work is that he looked at the association between regularity and frequency according to these 3 indices. So on the y-axis of this graph is the relative frequency of GP attendance, where 0 means that there's actually no difference compared to the least regular in the 3 indices. So for the variance index, which is the existing regularity score, you can quite clearly see that as we get more regular, the relative frequency of those individuals increases. So there's a high correlation with frequency, and this is why we have to put frequency as a variable in our models to adjust for that. For the relative variance, the new regularity index, you can see that there is still an association, but it's in the opposite direction, but it's also much smaller. Whereas for the interval index, you can see that there's clearly a similar to our regularity index, a highly positive correlation between the measure of regularity and frequency. So then the second aim was to have a look and see how this actually affected any of our modelling to do with an outcome of, in this case, diabetes-related hospitalisation. And what we've got is the same 3 variables, the same 3 metrics, but this time we've done a model without frequency, which is the blue bars, and a model with frequency, which is the orange bars. And you can see for the variance index that for sort of moderate levels and low levels of regularity, there is actually small but non-significant changes, reductions in the outcome, and the measure of the outcome, if you like, when we put frequency into the model. Whereas with most the high regularity, there's still a reduction, although it's just barely not significant. For the relative, that was our existing regularity index. For the relative variance index, you can see that there's now very little difference. There's a little bit of a difference in the most regular group, but again, it's not significant, and it's much smaller than it was. And for the interval index, you can see very similar findings as we would expect looking at the phase 1 results with the variance index. So our new regularity indexes, which we've been using going forward, means that we are less reliant on frequency, is a less of a confounder, although we do need to still put it in the models because of the issues with the most regularity group. So the next piece of work that I just want to sort of highlight is some work that I've been leading, which is about the association of continuity of provider adjusted regularity in GP contexts. And this is really, we thought about doing this work because in our old data, we had the MMBS items, but we didn't have a de-identified provider code. So we really couldn't account for whether regularity was actually really a proxy for increased continuity with a particular provider. So we've previously reported decreased rates and costs of diabetes-related hospitalizations, and this suggests that regularity is a suitable target for policy intervention, and that also primary care is indicative of this proactive management of a patient as opposed to reactive or unplanned care. And we've seen that from our results of people who access the EPC items have an increased regularity, but without an increase in frequency of GP contact. But as I say, really a limitation of this work is this inability to adjust for continuity of provider. So the MBS data that we got with the 45 and up study, and also with our new WA data set, which is we've only actually got access to in the last 3 months, so I'm not actually going to show any results from that, means that we have this de-identified provider code, and this means we can calculate this metric called usual provider of care index, which is really the proportion of GP attendances to the most frequent provider, and it gives again a score of 0 where that there isn't a most frequent provider, to 1 where all the GP attendances have been to the same provider. And this is really, as I say, to answer this question about is regularity actually a proxy for increased continuity of provider, or is it a discrete facet of continuity of care? So this is a bit of a busy slide, but really we captured the diabetes cohort using the 45 and up study and been data. We used self-report initially. Those who didn't have a self-report of diabetes, we looked at their hospitalizations, and those that didn't have a hospitalization, we used PBS dispensing for diabetic medicines. We had to get rid of a few cases because of potential linkage errors, and what I mean by that is people who died but still had hospitalizations, etc. We wanted at least 2 years worth of data in our cross-sectional cohort, so we excluded people who died before the 1st of July 2011, and also in this particular case, less than 3 GP visits during the study period were excluded, and that's because the calculation of UPC really needs 3 GPs, otherwise you're just getting sort of a 50-50. If you go to 2 different GPs, it's very difficult to score. So very in brief, I'm not going to go through the statistical analysis, but really we used here 2-part models. We used a logit model to determine the probability of positive outcome, and then conditional upon that positive outcome for the count outcomes, which were rate of hospitalizations and bed days, we used negative binomial models, and for cost we used a GLM model. Models included both regularity and UPC, obviously, because we want to, the whole point of this study was to adjust for UPC when we looked at the impact of regularity. But we also included an interaction term and evaluated whether that interaction term was actually significant to look at whether there was an effect modification by UPC on the impact of regularity. And all models use robust standard errors. So some very high-level results here. This is the results for unplanned diabetes-related hospitalizations and or ED presentations. And you can see here in the y-axis, we're looking at changes in probability compared to the lowest regularity in the rate of hospitalizations. And across the bottom, we've got the indices of regularity. So we've got low, moderate, high, and highest. And we can see here that increasing regularity adjusted, remember, for continuity of provider, significantly reduces the probability of having an event. So this logit model, this starting with no events, so like ever, never, if you like. However, when we did the conditional model on rate of events, it was not associated with changes in the rate of events. So as long as people were having events, regularity, once we adjusted for continuity of provider, didn't actually change the rate of events those individuals had. When we look to see what the interaction, does this differ by UPC, we tested it formally in the paper, but you can see here by the fact that the lines are parallel that there's actually no difference. Those who've got a high usual provider care index, high continuity of provider, don't have any difference in the effect of the impact of regularity compared to their counterparts with low usual provider. And you can see that for both the logit model and also for the rate. So as far as days in hospital and annual cost, increasing regularity was associated with a reduction in days in hospital, as you can see there, and also a significant reduction in the annual cost. Now, obviously the LOGIC model was the same. You've either got a hospitalisation ED presentation or you haven't, but we've got quite different results here than we showed for the rate of hospitalisations. And I know, thinking about this, the reason that we always look at these three outcomes is because they measure slightly different things. You know, we know that, for example, having interaction with a primary care physician may actually put people into hospital. We may actually see almost a reverse causation in that we see people going to hospitals more frequently than people who don't interact with their GP. And that's because the GP may pick something up appropriately and it may be only treatable within the acute care sector. However, if you're thinking about the theory of ambulatory care sensitive conditions, what we would expect to see is we would expect to see the person's severity of that condition, the exacerbation that requires treatment, to be much less severe than if it was left on its own and the patient then had to go to the GP because of actually seeing those symptoms. So we would expect measures that show the sort of quantity of the burden, if you like, of that hospitalisation to be lower. So we would expect lower bed days and lower costs, and that is exactly what we're seeing in the data. So again, does this differ by UPC levels? And we can quite clearly see no, the results are slightly not quite as parallel for the rate. We can see there's a slight widening when we get to the highest UPC, but it certainly wasn't significant, the interaction term in the testing. So the conclusion, this was the first study to assess regularity adjusted continuity of provider of care, and we showed an inverse association between GP regularity and the probability of an unplanned diabetes-related hospitalisation or ED presentation. We saw there was an inverse association with average annual bed days and also average annual cost. And really what this means is that regularity is not just a proxy for continuity of provider, but that the continuity of provider and regularity should be considered as distinct phenomena. And that we also showed no effect modification by continuity of provider, and this has implications for incentives that support ongoing contact with the same provider with or without a focus on regularity of care. Regularity of care by any provider, or whether we actually encourage regularity of care for the same provider. What we're not saying here in this particular work is that regularity of care by the same provider is not useful, because I'm absolutely convinced that it is. But what we're saying is regularity is distinct in its own, and regardless of having that regularity provider, it still has an impact, which is obviously very important for the Australian healthcare system compared to, for example, the UK system, because we don't really have this history of having a family practitioner. So the final piece of work I wanted to actually just highlight is a piece of work done by our newly minted PhD candidate, who's just had her results and got through all the assessment process, and now is Dr. Ninh Ha, and she looked at developing a completely new measure. So she's looking at developing this idea of a time duration measure of continuity of primary care. So the rationale for the new metric is that it includes a dimension of time. As we've discussed, regularity of primary care contacts are an important aspect of continuity of care and potentially suitable for a target for health policy. But currently, both our regularity measures, including the new one, have no inclusion of time between visits. So a regular visit could be one visit every year, or it could be one visit every month. It could be one visit every day, but obviously we don't really want people to go to the doctor every day. And this would very much depend upon the condition, the severity of the condition. But the idea here is that if you leave it on a hypothesis, if the interaction of the GP isn't happening frequently enough in times of space, of time, then any protective effect that interaction of the GP have as far as prevention, as far as monitoring and management of your chronic condition is lost over time. So we're here trying to think about this idea of an optimal time period, and we've actually coined this metric COVER. So the COVER metric is the idea that a GP presentation has a warranty period, okay? So it has this period where if you go to the GP during that period or at the end of that period, you will be under this idea of this protective effect. But if you leave it too long, then that protective effect starts to wane. So that ideally the next GP visit should be at the end, towards the end of this time period, provided you don't have anything, going on with your condition during that period of time, exacerbations or flare-ups. So if we think about this little diagram here, the grey areas are at the idea of the warranty period. So we can capture within any period of ascertainment for an individual using the MBS data and knowing what this warranty period is, the days either under warranty or outside of warranty. And we've chosen to actually capture days under warranty. And this gives us a value of 0, 1. So it includes this idea of a time period. But what it also does is it gives the 0 to 1 metric in cover sort of a value that we can conceptualize clearly, whereas the regularity index is meaningless. Metrics like UPC have a value in that if we talk about 1, we're talking about 100% of the GP visits are by one provider. If it's 0.5, it's 50% of the GP visits by one provider. When we talk about regularity, we talk about, well, we're just saying it has perfect regularity, but we don't really have an idea of what that dimension is. Cover has a natural dimension in that when we say 1, we say that 100% of time, of the ascertainment time, is captured under this warranty period. Whereas again, if we say 0.05, we're saying that only 50% of the time is. So it's much more meaningful, if you like, to policymakers. So in this particular piece of work, Nin actually did an empirical estimation of the warranty period. So the cover period, as we've discussed, is about the maximum time interval between GP visits. And this was idea is actually empirically estimated from the data to give the time period that resulted in the minimal number of hospitalizations. She estimated it using threshold effect models. Now, I'm not going to go into detail here, but these are models proposed by, they're econometric models proposed by Brenda Gannon et al. And they're a version of latent modeling where basically you're searching for sample heterogeneity in the response outcome to variations of the predictor, where the predictor in this particular instance is time in months. And this helps you identify subpopulations. So the data that Nin used were all adults, was the old WA data again, because it was just theoretical. Hospital records and Medicare claims were used to identify the study population. We restricted it to people who were aged 45 plus, and she looked at the outcome as being diabetes-related potentially preventable hospitalizations from those data sources. So from the previous piece of work in her thesis, Nin had already actually done a piece of work that actually split the diabetes cohort into groups that had very similar types of hospitalizations. So these were people with 0 complications, people with 1 to 2 complications, and people with 3+ complications. And then what she did was did the threshold effects model. Now this slide, I don't expect you to, I've already put on the screen so you can see what the output looks like, but the numbers highlighted in red are really, it basically searches through a number of models and it comes with the model with the best fit, and it gives you, in this case, our time is in months, the number of months that is the ideal, the optimal time for those particular 3 cohorts. So for people with diabetes with no complications, it was 13 months, for 1 to 2 complications 11, and for 3 or more complications 9. Now you can also look at this graphically. It's quite difficult to see, I must admit, between 0 complications and 1 and 2, but in 3 or more complications, you can quite clearly see where the red arrow is, where we're basically on the y-axis, that's of the potentially preventable hospitalizations, that is reduced, got to the lowest level, and after that point, once we get to longer than that time period, it starts to increase again. So the cover metric is then calculated by just simply enumerating the total number of days under GP cover using this optimal maximum time period interval found in the threshold effects model for each person, depending on what clinical cohort they lie under. Now, we had to make an allowance for people who were in hospital and then came out of hospital, and our GP panel sort of thought that 14 days was a reasonable period of time where we would expect to see a GP. So what we did was if they had a GP attendance within that 14 days, we started using counting again from that GP attendance. If they didn't have one, we on the 14th day we started counting from then, because then they were out of cover. And then you also enumerate the total number of days in the ascertainment period, excluding days in hospital or temporary residence outside of WA, because these aren't periods of time when they are covered by WA GPs. And the proportion of time, the cover index therefore represents the proportion of time that an individual is under GP cover over this pre-specified ascertainment period. Now, this was a very theoretical piece of work. She's got another paper that's currently under review, which is actually using this data in contemporary 45 and up, this method in contemporary 45 and up data. But what we wanted to do was have a look and see what the face validity of this metric was. So she had a look to see who was being captured with high cover and who was being captured with low cover. So overall, in the diabetic cohort, there was an average of about 86% of cover for people. But those with low cover were people who were aged 75 years or older, males, those with indigenous status, those with high disadvantage, and those living in very remote areas. So this gives us some idea that there is that the face validity of this index is fairly good, because these are exactly the people that we know have poorer access to general practitioners. So in conclusion, for this particular study, the cover index has updated our concept of regularity by added this idea of a time dimension, and also provided more meaningful units. We hope that this will contribute most to the sparsely available methods to analyse linked administrative data, but it's not limited to just GP care. We can actually measure any type of access to health services using these type of metrics. And although in this particular example we use this threshold modelling to estimate empirically this warranty period, we can actually operationalise cover fairly flexibly. We could, for example, use expert opinion to define the optimal time period between the GP visits, or use clinical guidelines to define the time period, in which case it would capture adherence. We can also model potential to actually impact change in frequency of visits. For example, we could impose different warranty periods on and then test out based, potential policies and test what that does to the outcome. So the next phase of our research, just to wrap up, is we have an NHMRC Ideas Grant application in 2019, which we're waiting with bated breath for the results of, as I'm sure a lot of people out there are. We didn't get FFC, so that was good. And this is about unpacking the dimensions of continuity of primary care, obviously regularity, our new regularity score, time duration of regularity, continuity of provider, and also continuity of practice, where we're hoping to, or we're still negotiating, this idea of getting a de-identified practice identifier. But what we're moving away from is, instead of looking at this idea of regularity or continuity of primary care directly affecting hospitalizations, we're actually thinking of how that actually mechanism works. What's the mediating factor with that? So obviously, if we think about what's really happening, the only mechanism that it must be happening is by better care. Things that we can measure in that realm are things like adherence to clinical guidelines, evidence-based practice, and things like reductions in high-risk prescribing. So I'd just like to leave it there. We're probably a little bit over time. It might be too bad, but I'd just like to acknowledge, obviously, the WA Data Linkage Branch for the older data, and also the Sachs Institute and the 45 and up study. And we'll open up for questions.
Okay. So thank you very much, Rachel. That was a fascinating presentation. I'll just now. People can ask questions. We do have some time for questions, and you just need to type your question into the question box, and perhaps we'll give you a moment or two to do that. Just to let people know that we have recorded the presentation, and we will be putting the presentation on our YouTube channel. Everybody who registered for the webinar today will get an email letting you know when the video is available. It usually takes us a few days to a week to get it up there, but we'll let you know as soon as the video is available, because I'm sure you might want to let some of your colleagues know that this interesting presentation is available and they should check it out. So I'm just having a quick look at see if we've got any more questions. yet? No.
There's two questions there, Felicity.
There are two questions.
It's a bit hard to read, but I can read the first one. How about continuity of clinic as opposed to provider, implying, hold on, I've got to, oh. It's very hard to read on here, sorry.
It's teeny tiny writing.
Tiny writing.
You're going to click on the actual question and it will come up in the bottom of your box.
Yes, no, it's not coming up big on the box either.
I can probably guess what they're asking. So do you want me to give sort of an answer?
Yeah, have a go.
Yeah. Okay. I presume by continuity of provider, it's what we're calling continuity of practice, which is our next part of work. So yes, obviously, when we're talking about continuity of provider, we're really talking about a particular GP, but GPs don't, you know, you may be going to the same clinic or the same practice to see a GP, and of course, GPs within the same practice will probably have much more access to the patient's records and history than an ongoing management than somebody in a completely different practice. So this is where we're actually moving to with our next piece of analysis. Unfortunately, there isn't an item directly available on the MBS, or we've been negotiating for about 3 or 4 years for this data, but we're actually negotiating to get what's called the PIP provider payment, which is the only sort of identifier that we can have, or that they've got for the clinic or the practice identifier. So we've had to go through a few legal issues, and they're still umming and ahhing about whether we can have it. And there's a few other people applying for this particular same variable. I don't know what they're using it for, but we're using it as a proxy for this idea of the clinic. But some work that's been done by Louisa Jorm's group with Michael Polster has actually looked at using network analysis to try and look at, so if we don't get this data, to look at patients who share GPs and GPs who share patients, and that will give us, if you like, a proxy for clinic, because obviously there's more likely to be continuity of care, or the opportunity for continuity of care, if you're going to see a GP within a clinic setting that can share information than somebody who's completely remote. So this is definitely the next stage of our work, that we want to look and see if that makes an impact. So hopefully that answered that particular question.
Okay, I have another question for you. With your diabetes-related complication, oh, now it's disappeared off me again.
With your diabetes-related complications or hospitalizations, did you just use ICD codes for diabetes, E10 to E14? Thanks.
Yeah, no, we didn't. We used those. In fact, we used all the codes that were in the that was PPHs in the quality framework, but we also used some work that in Western Australia by Wendy Davis et al., where she, in the Fremantle diabetes cohort, where they actually looked at hospitalizations that had increased relative risk in diabetes patients compared to non-diabetes counterparts, and we actually included those hospitalizations as hospitalizations that were likely to be related, or more likely to be related to hospitalizations, so where diabetic patients were more at risk, if you like, of those hospitalizations.
It's another question from Lachlan. I'm wondering whether you collapse multiple GP visits that occurred within a certain range of time, for example, multiple visits within 7 days, to account for follow-up consultations for the same condition.
Yeah, in regularity, the regularity score, we don't. We count GP visits currently. We call them GP days. So obviously, if you have more than one GP visit in a day, it doesn't get counted, but we count GP days. But in Nin's work, she has done that. What we thought, we actually had our expert GP panel was looking at how long would you expect to, you know, when would a GP, because we don't know why they've gone to the GP, we only have the MBS item number, but obviously going back to clinic for results of tests, etc. So Nin, I think she used, actually used, varied it between 7 and 14 days. I'd have to ask her to be absolutely sure, but certainly it was between sort of 7 and 14 days that she encountered. It's been not a new initiation. So that's one thing we did thought about, but we don't do it actually in regularity. And in fact, when in the regularity score, and when Nin was doing her work and we were discussing this, I was sort of thinking about what we should do with regularity. So that is something we can definitely look at to see if it changes the regularity score, because that would sort of, you know, if people are going for actual regular catches up, but they're having tests and then they're coming back for the test, that will sort of make the regularity score worse. Okay.
And there's one last question. The time from start of ascertainment to the first contact and time from last contact to end of ascertainment period is treated as measured time between contacts when it doesn't actually seem to be, since the prior and later contacts are not actually captured in the ascertainment period. What is the impact on this results?
Yeah, what we do is we don't actually do that. The graphic is not quite correct in that respect. What we do is we have a look back period. So whatever the ascertainment period is, whether it's a year or 2 years or whatever, we look back to the previous GP prior to that ascertainment period, and similarly at the end we actually look back to the next GP after the end of the ascertainment period to incorporate that into the regularity score. So we always have data at either ends of wherever we're actually measuring regularity that we take into account. In the first very iteration of this work back in the old days when we did the EPC study, we actually did it as a circular loop, but since then we've actually got more data because we've got data from 1984 right the way through to 2005. So we actually cut off we always have a year at that end, and we have quite a number of years at the bottom end. So yeah, because that would make it to be a false, it would disrupt the irregularity score.
Okay, so thank you so much, Rachel. That was fabulous, and I'm sure that everybody attending learnt a lot. So thank you once again. I'm just going to finish by reminding people that the PHRN is having their 10th anniversary this year, and next week on the 21st of November we're having a big symposium at the Sydney Opera House. There are still tickets available, and particularly if you happen to be in New South Wales, that might be of interest to you, and I really encourage you to come along next week. So thank you, everybody.